Hey all, welcome back to the Real Life Pharmacology podcast. I am back to focusing on specific medications here for a little bit. So if you have any requests, suggestions, I can definitely take a look at and see if I can get them on the list here to cover. So with that said, always go to reallifepharmacology.com, get your free study guide, just 31-page PDF on the top 200 drugs. Great no-brainer to have that refresher. Or if you're in pharmacology classes in college or whatever the case may be, definitely may be helpful there for you as well, as I include some of the most important things you see in practice as well as that show up on board exams. All right, so the medication I want to cover today is Modafinil. Brand name of this medication is Provigil. This is classified as a central nervous system stimulant. With that said, kind of that general classification also includes medications like amphetamines, for example. So medications that can be used for ADHD and things of that nature. In kind of a generalized scale, it's not always perfect to do it this way because a lot of it's dose dependent as well. But generally, I would classify medication like Modafinil maybe a little less potent of a CNS stimulant compared to some of the meds for ADHD, for example, like Adderall and things of that nature, methylphenidate. So with that said, again, that's a relative scale based upon dose and other things included there. But that's kind of my initial thought process when I think about this medication here a little bit. So Modafinil, from a mechanism of action standpoints, it increases dopamine, but it typically isn't as potent as the amphetamines. It does that by essentially blocking dopamine transporters in the brain, so it increases that dopamine activity. Another thing that has been looked at, the mechanism isn't crazy well understood, but there's some potential that it can decrease GABA-mediated neurotransmission. So recall that GABA is an inhibitory neurotransmitter. So if we block that, if we reduce that, in theory, we're going to get more CNS stimulation, which obviously helps lead to explain what Modafinil does in the body there. There's also some potential enhanced activity of 5-HT2 receptors that can affect the alpha-adrenergic system. So again, not crazy well understood how this medication works, but there's definitely some evidence and some theories as far as how it provides its stimulant type action. Okay, so where do we see this medication used? So I alluded to it being a stimulant, so it rarely is used for ADHD. I'll start with that one, just tying it back into other stimulants. But again, not very often is it used for this. It's more in refractory cases where, obviously non-drug interventions, non-drug therapy has failed, as well as other medications. So it's definitely a refractory option. And probably the big reason for that, particularly in pediatrics, is we can cause some skin reactions as well as psychiatric risks too. So, which I'll get into the adverse effect profile here coming up. Other indications. So, first off, going back, that ADHD indication is off-label. The FDA-approved indications, primary one that I see in practice is narcolepsy. So this is obviously to help with that wakefulness in patients that have excessive daytime sleepiness. Other potential indications, you may see it used for obstructive sleep apnea. Again, this is, kind of to, decrease that feeling of fatigue throughout the day. And shift work sleep disorder for those that have trouble staying awake during those kind of off working hours. Other things, basically anything fatigue related, cancer, depression, Again, these are off-label type situations, and again, I don't see it used terribly often for this, and I really don't like to see it used terribly often for this as well. And one of my biggest concerns that I've seen, particularly in geriatrics and polypharmacy, is I've seen, patients on, benzodiazepines, high-dose opioids, maybe undiagnosed hypothyroidism, or, labs haven't been assessed and the patient is hypothyroid and that's the cause of their fatigue. First generation antihistamines such as diphenhydramine, sleeper medications. These are all medications and situations that I've seen where we've tried to use a stimulant like modafinil to, give a patient more energy, but now they're taking a stimulant alongside of, other medications that do the exact opposite and cause sedative type properties. Okay. So if you ever see a prescription, for a medication to kind of stimulate energy or give them, keep them awake during the day, your first step should be to go look at that medication list and make sure that they aren't on some of these sedative type medications. Because I have seen it numerous times where we've tried to use a stimulant to get rid of fatigue in somebody, and they're taking, benzodiazepines as well as sleepers and other medications that have sedative properties. So, very, very important point there to make sure that we're helping our patients in the best way possible and obviously minimizing polypharmacy. All right, let's take a quick break from our sponsor, meded101.com. If you're in the market for any pharmacist board certification study materials like NAPLEX, ambulatory care, BCPS, BCMTMS, geriatrics, go check out meded101.com/store. We've got a growing list of resources there that have helped thousands prepare for and pass their board exam. So go check that out, meded101.com/store, support the sponsor, and help support this podcast. All right, moving on, let's talk a little bit about pharmacokinetics. Probably the biggest thing with pharmacokinetics, maybe a couple things, is recognizing that half-life. A half-life is in the neighborhood of probably half a day. So when we dose this medication, we're typically going to give, 100, 200 milligrams in that range. When we dose this medication, we want to be careful not to get it too close to nighttime and that we're causing insomnia. So typically this medication is going to be dosed early in the day, and that's on account of its pharmacokinetics. Because if you get it too late in the day, we're going to keep that patient up, and that's goes against probably what we're trying to do and maybe what we're trying to help with there. So that's one important point. And we do also have some issues with CYP3A4, and I'll get into that in much more detail in the drug interaction section for sure. All right, moving on, let's chat side effects a little bit. So knowing that modafinil is a stimulant type medication, you can probably guess some of the potential adverse effects. Insomnia, anxiety, nervousness, maybe some GI upset, potentially headache, also reduced appetite. Probably, most concerning if this medication is being given to pediatric patients. We definitely don't want to do anything if they, need nutrients, need to eat for growth, that type of thing. We don't want to reduce that too much, of course, there. And then with that stimulant type activity, certainly we can have some issues from a cardiovascular standpoint. So we can have increased heart rate, elevated blood pressure. That's something that you're probably going to want to monitor with this medication. Be very, very careful in patients with pre-existing heart conditions. Obviously, anything that we do to increase that heart rate, increase that blood pressure, put more stress on the heart, that's a potential issue and something that we need to be a little bit careful with for sure. Psychiatric symptoms have been reported with this medication, maybe more aggression and agitation, hallucinations even. In patients with bipolar disorder, very, very important to recognize that this can induce mania. And I have seen a case or two where actually somebody maybe wasn't diagnosed yet with bipolar disorder, and stimulant like modafinil was started, and it actually induced mania in that patient where that diagnosis was not yet recognized. So again, pay attention to that. Probably not a great medication to utilize in patients with significant psychiatric history, or at least if we do use it, we got to be really, really careful, really monitor those patients a little bit more closely. And then the other thing, again, psychiatric symptoms, cardiac issues, those are fairly rare. Same thing with Stevens-Johnson syndrome. Definitely something that we need to look out for, but again, it's pretty rare overall. The more common things you're going to see are the insomnia and anxiety, maybe a little GI upset, and those type of things. Last but not least, with the adverse effects, I do want to mention that it is a Schedule 4 controlled substance, so we do have some risk for dependence and addiction there. All right, finishing up with drug interactions, and that reminds me, go check out Drug Interactions in Primary Care. It's a book I put together. Great reference for you. It's on Amazon. No-brainer to have that book. Lots of great examples in there. So with that, drug interactions in regards to modafinil, it does have some CYP3A4 inducing activity. So any medication that is broken down by CYP3A4, modafinil does have this potential to reduce the concentrations of that medication. Okay? So this can be a challenge because there's lots of medications that are broken down by CYP3A4. You've got, medication like a calcium channel blocker, like diltiazem, for example. Some of the benzodiazepines, like midazolam. There's statin medications. Many antipsychotics are at least partially broken down by CYP3A4. Antibiotics like clarithromycin. So these are all medications that may have their concentrations reduced, and we could, potentially see some treatment failure there. Now, is it an absolute contraindication? From that perspective, I would say no. But I think it's good to recognize that if you're going to use modafinil, you better understand that we could reduce the concentrations of many other medications. Probably some of the more sensitive ones that I did want to mention. So there's some anticonvulsants like phenytoin or carbamazepine that may have their effectiveness reduced. So obviously, if we're using those medications for seizures and preventing seizures, and now we, add on modafinil and reduce the concentration of those medications, now we could potentially put them in a subtherapeutic area. And that could increase the risk for a seizure. So again, be very, very careful if you've got a patient with seizure disorder and taking some anticonvulsants and using modafinil there. The other one I wanted to mention was oral contraceptives. So CYP3A4, plays somewhat of a role here as far as breaking down estrogen and medications pertaining to oral contraceptives. So ultimately, that could reduce effectiveness and potentially lead to a situation where we increase the risk for pregnancy. So we may want to consider non-hormonal methods to prevent pregnancy in patients that need to utilize modafinil and they're taking oral contraceptives. And then, of course, I want to remind you again one last time of that yin versus yang, the sedation versus stimulant type activity. Medications like alcohol, benzodiazepines, Z-drugs like, zolpidem, first-generation antihistamines, hydroxyzine, diphenhydramine. These are all medications that are going to oppose the effects of modafinil. Okay, those are sedative-type medications. So we need to be really, really careful about that, really, really aware of that, and making sure that we're, not fighting each other, basically, with 2 different medications. All right, well, that's going to wrap up the podcast for today. Thank you so much for listening. Please do me a huge favor, leave a rating or review on iTunes or wherever you're listening. I greatly appreciate that. Please share us with friends, colleagues, students, anyone who could benefit from some pharmacology education. Of course, as a reminder, I've done over 300 episodes of individual drugs. Go check those out. Go search reallifepharmacology.com under the podcast tab. Search for the drug you're looking for if you're studying or want to beef up on a specific medication. We've got hours and hours and hours of content now at this point. So go take advantage of that. Absolutely no cost to you. And of course, support the sponsor, med101.com/store. Any purchases there go directly to help support this podcast and keep it free and available for all to benefit from. If you want to reach out to me, mededucation101@gmail.com. If you got any suggestions, anything you'd like more info on as far as future podcast episodes, I do my best to accommodate. Sometimes all the questions don't fit with what I want to do, but yeah, don't hesitate to reach out. I do my best to try to respond to everybody. So again, mededucation101@gmail.com. If you want to connect with me on LinkedIn, you can do that as well. Eric Christensen, PharmD, BCPS, BCGP. And with that, I'm going to sign off for today. Thank you so much for listening. Take care, and I hope you have a great rest of your day.